Hello, everybody. My name is Jason Sorrow. I am on the Fitness, Health, and Wellness Committee of Strand, and I welcome you all here to our lecture tonight by 360 Orthopedics and by the Reed Medical Group. We'll be introducing the doctors in just a few moments, but I wanted to get talk to you about a few things. First, I want to first introduce you to our committee. I'm not sure how many of you have been to our lectures or know that we have arranged, I think, perhaps a lecture every 2 weeks throughout the in-season. We've had topics including elevated plate lecture on healthy eating, lectures on ergonomics, lectures by physical therapists regarding pickleball and golf mechanics. We've had Medicare lectures. We've had physical therapists, and we are ongoing. We have an eyeglass drive going on now for donations through the Lions Club, which will be done in May, but we have the pickup box, the donation box, already in the main clubhouse area. We organized the walking club for this season, and we'll be starting it up again next season too. We do have already our calendar for April. Beth Abarca has a recce session every Thursday morning at 8 a.m. On April 10th, Elite Fitness Physical Therapy will be lecturing. On April 17th, Xander Chowie will do a workshop on knee and hip workshop in the fitness center. On April 22nd, the Roscap Institute will be here and talking about new developments and thoughts about dementia and Alzheimer's disease. There will be more throughout the season. We're going to cut down to one lecture per month during the summer months, but hope to pick it up with a vengeance starting in next season, certainly in January. Who here has lived here more than 5 years? Who here more than 10 years? Who thinks they know the neighborhood well, community well? Who thinks they know it really well?
And that's why she's the
Because we have April 11th, Friday, we have a River Strand Community Adult Scavenger Hunt planned. It's going to be teams of 9 to 12 that you can either form a team yourself or sign up and have people join with another team. And the goal will be to find things from a hunt list that are in our community that you have seen every day but may not pay attention to. The idea is to move around the community, so while you may just stay local, bicycles, rollerblades, anything else are encouraged to be used as well to try to explore the neighborhood and find these things for points and for prizes. So,
very great.
And we're aided in this by Kara Schlick, who works with us to get quality lecturers on a variety of topics. And again, we'll be like to hear your thoughts on what topics you would like to have, and we'll be doing them again regularly starting next season. So this is the first of our group physician lectures, but I'd like to welcome you all here. Not here yet, right?
He's at the main gate.
Okay.
He's speaking last. It's
So
fine.
I'd like you to hear and give a hand for Kara Schlick.
So thank you, Dr. Sorrow. Thank you very much. And then I just want to thank Julie and Kelly and Deborah for helping me arrange this. I think we met in June, right? And now we're finally here, so this is really great. So we'd love to bring this back to you in January and maybe even February and March and tell us the topics, and then we'll bring well-qualified physicians. So today we have 3 physicians that are presenting. We're going to start with your internal, or like a family physician, internal medicine. Dr. Mindy Ward is internal medicine. She's from Reed Medical Group. And then we're going to talk about different ways of healthy aging and preventing dementia. And then that leads us into Dr. Mahoney from 360 Orthopedic, who's a general orthopedic but loves hips and knees. who specializes in hips and knees. So all you pickleball playing, hips and knees. And then we're gonna finish with Dr. Claire, who specializes in foot and ankle. So that's more the probably pickleball players as well, right? So I'm gonna introduce Dr. James, oh sorry.
I'm gonna jump back in because I can never go up a stage
Okay.
easily. I'm sorry.
So I'd like to introduce the head of Reed Medical Group. Reed Medical Group is a concierge family internal medicine practice out on Longboat Key. And after 3 years, Dr. James Reed, who's the owner who I'm going to introduce, is opening up a Lakewood Ranch office. So at the end, if you have any questions, you need a primary, you need a family, internal medicine doctor, maybe Reed Medical. So let me introduce the owner of Reed Medical Group, Dr. James Reed.
Hey, good afternoon, and thank you for having me. As Kara said, my name is Dr. Jimmy Reed. I moved here in 2017 from Greenville, South Carolina. I worked for HCA for 4 years. You know, I decided at some point it was time to do medicine the way I thought it should be done. So I started Reed Medical Group on Longboat Key. You know, we're 3 years in at this point. It's taken off like crazy. So we're opening up an office in Lakewood Ranch, and we're also opening up an office on 59th Street in Bradenton. In addition to that, we do a lot of convenient care, like delivered to people's homes. So, and telemedicine, with the concierge packages. So there's a lot that we can offer, but Kara told me I can't talk long because I need to move it on. But, so we have an innovative, really common sense, high level approach to your healthcare. And if you want to talk about it later, I'm more than happy to stay here and answer some questions for you. But yeah, just due to demand, I brought on 2 new doctors. Dr. Mindy Ward, she joined me in July. She did a residency here at Sarasota Memorial, so she knows the community well. She's worked in the area, came from another big group in the area, so she practices with me on Longboat Key. Bettina Schutzbach, we went to residency together. She was our chief resident, and she's joining the practice, starting now. She's going to be working at our Lakewood Ranch and Bradenton office. So anyway, I've rambled enough for now. I want to take a minute to bring Mindy Ward on. She's going to do a lecture on healthy aging and the prevention of dementia. So let's take a minute to welcome Mindy.
Being a physician is one of the greatest privileges of my life, and one of my favorite things to talk about is preventative medicine and how you can live your best life and make sure you play pickleball and golf and all the things that you love to do as long as possible. So thank you so much for having me here to do that. This is me. He kind of already said most of it. This is Dr. Reed. And then, like he said, we're out of Longboat Key and we're expanding, so that's exciting. So researchers calculate that 45% of all dementia could be prevented. And then it's really exciting that with new treatments, even the 45% that isn't prevented is likely going to be treatable in the future. So there's so much hope, which is really exciting for a disease that has claimed so many people. And it's one just that's scary to think about in the future. So to start with, type 2 diabetes is one of the most exciting things that we are aware of now that can help prevent dementia. So it's not exciting to have type 2 diabetes, but we've never lived in a better time to treat type 2 diabetes. There's so many new medications, and even some of these medications are being studied specifically to help prevent dementia. So the GLP medications, such as Mounjaro and Ozempic and all those things that you hear about are important in helping keep people's A1Cs more steady, because when blood sugar is involved, the steadier it is, the better. So don't be afraid of having diabetes, and if you do have it or any pre-diabetes or concerns of it, be empowered that that's one thing that you can really work with to help prevent your risk of dementia. Hearing loss. Hearing loss is a big thing. I always hear that my TV is too loud, or oh yeah, they have selective hearing, or the favorite joke people always tell me is I say, how's your hearing? And they say, what? And it's actually one of my favorites. But so I say that to say, if you have any type of hearing loss, go get it checked. This Costco in Sarasota is one of the busiest centers in America due to the demographics, and they're really great at it. Sam's Club, anywhere you want to go, get your hearing checked. And if you have any type of hearing loss that they think they can help with hearing aids, then don't be afraid to use them. They say there's a 40% decreased risk of developing dementia if you treat hearing loss. And that's a phenomenal statistic for me. It helps prevent social isolation, and it helps prevent depression. So don't be afraid to treat it. And then next, depression. Depression's a really difficult one because it's unclear if dementia causes depression or if depression causes dementia. They definitely seem to be correlated, but if you're feeling outside of yourself, if you are usually a happy person and you're feeling down or something has happened and it just affects you and you can't seem to shake it, don't be afraid to talk to your physician or whoever you have around you to treat that. There's all kinds of different types of treatments, and because depression itself increases stress hormones that cause increased proteins in your brain that we see likely leading to Alzheimer's. Just like hearing loss is a big one, reading is equally as important. So if you notice that your eyesight is changing, then don't be afraid to go change your glasses, because it's important to be able to interact with reading menus. How many of our communications are via text? If we can't read our text messages, how do we even communicate? And then reading just on the day-to-day. I mean, I know I love to read books, and so making sure that you have all the tools that you need to interact in your life in a way that is productive. So education is an early thing. We can't really all affect our early life education at this point. The more early life education that we had, the lower risk of dementia that we have. But lifelong learning is something that we can change. We can do puzzles, we can do reading, playing games, drawing, painting, doing scavenger hunts. I like that idea. Working, volunteering, all those things are phenomenal. So don't be afraid to engage in the community around you. There's always somebody who would benefit from you, and you're literally helping yourself as well as helping others. So that is a phenomenal way to interact. Just like I want you to be social, I don't want you to be isolated. Being lonely is lonely. You can do things like groups. I personally love animals, volunteering, relationships. Don't be afraid of therapy. You're never too old to, figure out what it is why you're feeling a certain way. And then treating the isolation and just working on not being alone. And there's also an interesting idea of being lonely and being alone are different things. So but if you're feeling lonely in any situation, then I really encourage you to evaluate it and see what you could do differently to help that feeling of isolation. Obesity. We know that this is something in America that lots of people struggle with. They used to go pretty much by the BMI calculation, which is your height and your weight gives you a number that tells you how obese you are or not. But now they do a lot of waist to hip ratios. So ideally your waist should be smaller than your hips, and there are some calculations out there to factor that. But keeping that in mind and working with someone to help decrease weight, working with a nutritionist to improve your eating habits, and then you are never ever too old to exercise. Look, resistance training. Resistance training is your best friend. So a lot of times people tell me that they walk on a daily basis, and while I love for people to walk, and that's great for your heart, I really encourage you to do some type of resistance training. Weights are what give you your metabolism, they're what give you your physique, and they're what give you your stability and will help prevent all types of falls. So, and no amount of weight is too small amount. If you can pick up 2.5 pounds and do something with it, then by all means do the 2.5 pounds. If you can, and that even goes for if you're gonna walk, put the 5-pound weights on your ankles or your wrists and walk with them, because it makes a big difference. And especially for osteoporosis, because half of falling is that you don't break anything, so you want to be able to fall well if that were to occur. And resistance training in your muscles are the best thing for that. Well, air pollution is not something we can control a lot. Thankfully, we live in a place that it's not a huge deal, but it is something that is to be considered. Excessive alcohol consumption. I know that in the 80s there was a study that came out that said that 1 glass of red wine for you a day was good for you. Unfortunately, since then there's been dozens of studies that have come out that have said that no amount of alcohol is a good amount of alcohol. It increases your risk of strokes, it increases your risk of heart disease, it increases your risk of dementia, and it increases your risk of cancer. So I'm not telling you never ever to drink, but I do encourage people to schedule when they're going to drink, because I know that in Sarasota, well, not Sarasota, Lakewood Ranch, and down here in general, every night is a drinking night, and if you go into a party, then you know you might start with 1 drink, but you have another one in your hand before you know what happened. And while I do want you all to live on vacation, and that's a phenomenal place to be, I want you to have your mind to do it with. So I do really encourage people to drink in moderation. Physical inactivity is one of the greatest things that in Florida we have the ability to prevent. I always say that people don't move to Florida to die, they move here to live. So there's never a better place to be in order to live. So as little as 2 minutes helps, so don't ever think that taking the stairs is a waste of time or walking to get your mail is not enough. Like, just a little bit of exercise makes a really big difference. Ideally 75 to 150 minutes of vigorous intensity every week, or 150 to 300 minutes of moderate intensity is more ideal. But you guys are in a great place and a great time to be able to meet those goals very reasonably. And then back to our strength training at least 2 days a week. It helps decrease your chronic inflammation, it improves the blood flow, and it increases the healthy proteins that are good for your brain. A lot of people know about smoking at this point in life. It increases your risk of dementia by 79%. There's never a time that's too late in life to stop. So if you, and I really encourage people, you know, like people say, oh, I don't inhale my cigars, like, if you're going to ingest marijuana, once again, I strongly encourage you not to inhale it. There's other forms. So any thing that our lungs are meant for air, so I really encourage everyone that smoking anything of any sort is not in your best interest. Cholesterol is a big one. Everyone, you know, lots of people don't love statin medications in these day and ages, and the medication can be scary just because of all the things we hear in the news and we don't know what the right information is. But it definitely repeatedly comes back in studies is that increased cholesterol increases your risk of strokes, it increases your risk of heart disease, and it increases your risk of dementia. So do not be afraid to treat your cholesterol. There are other ways besides for just cholesterol, or besides for just the statin medicines. They have injections with Repatha and other things at this point, but there's definitely correlations between Alzheimer's disease and high cholesterol. So if you have high cholesterol, if your physician is repeatedly telling you that, don't be afraid to go do something about it, because it's worth it and your brain is worth it. Menopause. I was reading a study the other day that like 55% of divorces are because of menopause, which I thought was super interesting. Yeah. You know, you guys are a generation that likely went through menopause in the early 2000s, so you probably heard a lot about the WHI trial, and there weren't a lot of hormones and things like that, and if you were on hormones, they took them away. And so for that, like from a medical standpoint, I'm very sorry that you guys went through that. And I wholeheartedly believe that we're working on doing better. So there's lots of different discussions about when is a good time in life and for how long in life you can be on hormone therapy. But if that's something you're interested in or concerned about, don't be afraid to talk to your physician about it. There's testosterone therapy, estrogen, and there's progesterone. And for men as well, like if you're suffering from lots of symptoms that you believe is due to low testosterone, as long as you don't have things that are scary, like contraindications, that is a possibility as well. So everyone wonders, if I have genetic risks, is there anything I can do about it? So there's 3 different types of genes that we're born with. We're either ApoE2, ApoE3, or ApoE4. ApoE4 is an increased risk of having Alzheimer's. If you have 1 gene, you have about a 20% increased risk, and if you have 2 genes, then you have about over a 50% increased risk. So with that, does that mean anything can be done, or is there just like a 1 in 2 chance? Lifestyle management for these patients was significantly more helpful than even in patients who didn't have these genes. So if you have a strong family history of Alzheimer's, or if it's just something that you're concerned about, or you randomly took the 23andMe and know that this exists for you, be encouraged that you have never had more control of it than now, and that lifestyle changes, as we've talked about, are within your reach to do something different with. Hypertension's another big one. I'm sure you hear doctors say like, oh, check your blood pressure, make sure it's 120/80. If it's greater than 140/90, let me know. So hypertension, just like cholesterol, is a silent, it's a silent killer. People are like, oh, it doesn't affect me, I don't want to take the medicine, I'm fine. But increased risk of dementia, increased risk of stroke, and increased risk of cardiovascular disease. So do not be afraid to treat your blood pressure. If you don't like taking medications, talk to your doctor about other things, but if nothing controls it, then control it with medications, because your brain, your heart, and your vessels deserve that. Is it too late? Just like we talked about, it's never too late. Even with cognitive decline, there can be improvement. I talked to Dr. Mauricio Concha, who does clinical trials, the other day, and he was super encouraged that patients that he was treating that had had some previous decline, 5 years later, they were seeing improvement. Now that was with medications, but even in these lifestyle managements, like you're not too far gone, it's not too late. Be encouraged that there's so much to do, and if you're still here, there's still hope. So go find some help. Oh, here we go. Oh, yeah, maybe we have time for a couple questions?
Yeah.
Does anyone have any questions?
Hey, I'd like to, because one of the things you mentioned was hormone replacement therapy. Maybe elaborate a little bit more of like, how we do a lot of the treatment for, hormone replacement for both men and women.
Yeah, so we do, so there's topical hormone replacement therapy, or there's injections. At the office, we also do pellets, which are 3 to 4 months for women, or every 6 months for men. And those are very effective, and you don't have to give yourself a shot, and that can be very effective in helping increase your hormones. And we have patients aged 40 all the way up to, I think, like 85 that are on hormones, and they're very happy and doing great. So there's lots of good data about it now too. Like those studies that previously came out, like I said, that were scary. There's lots of things that have showed that it's perfectly safe.
Is that wrapped in a concierge type service?
Yes, so we are concierge doctors, and there's a membership to be a part of our practice.
But
Yeah.
we'll do the hormones separately though too. It's, because especially, well, I started out doing that, but we absolutely have some packages that is just the hormone replacement side of things.
Okay.
Yeah. Yes, sir.
You keep talking about Alzheimer's. Alzheimer's is the most common of the 4 types of dementia, including
Correct.
vascular.
Right.
Are the numbers that you quoted specific for Alzheimer's, or do they include the vascular dementia?
They are definitely, so he's got a great point. Dementia is an umbrella, and then there are different types of dementia that live under that umbrella. These slides were more specific to Alzheimer's in general, but vascular dementia is very related to hypertension and cholesterol. So there's that. And then Lewy body dementia and Parkinson's, there's definitely more discussions about like where they originate. It's more of a gut-brain axis that they continue to talk about. I'm hopeful that they'll come out with more information about that in the future. But I mean, I don't think you will ever lose out by following these things, and like the hope is definitely there, and they're very tangible things that we are able to control. Yeah.
Are there checks that you can have to see how?
Are there checks that you can have? Absolutely. So there's neurocognitive testing if you're wondering where your brain is and how you're currently doing. That's like a 4-hour test. We do not specifically do that. We usually refer to neuropsych. But there are tests, and then there's actually lots of new good like PET scans of your brain that you can see the proteins and if they are present, and if the new medications would be able to treat you. And then there's some other stuff as well that is coming pretty rapidly about how they're diagnosing diseases and things like that.
The Roskamp Institute will be here April, check the date. They study the brain, including and especially Alzheimer's, and they actually have a free service of neurocognitive testing and programs that you can get into if there is some evidence of.
When were they going to be there?
Julie's looking it up right now. April.
Yeah.
With all other risks being are there any studies done on people, long-term survivors from surgeries of benign brain tumors?
Of benign brain tumors, having any type of brain injury can be a risk factor, but just like everything else, I think that within these things, just having the highest functionality is possible. I don't know that I've read anything specific about benign brain tumors. I don't know that I have. But I think that just like anything else, it absolutely is a risk, but doing the best you can with everything we
I
got.
haven't seen any specific studies.
No, I mean, I'm sure there's out there, I just have not seen them specifically, I apologize. Anyone else?
Thank you.
All right.
And Dr. Ward will be hanging around afterwards. If you have any specific medical questions for Dr. Ward or Dr. Reed, they'll be here afterwards too.
Okay, all right. I can do it. Right on. I think we got it. All right, good afternoon, everybody. Appreciate you coming out. I'm Dr. Mahoney. I'm one of the joint replacement surgeons at 360 Orthopedics. Hopefully you take a moment to look through over here. We got, pamphlets for everybody in the practice, but trying to provide, 360, so comprehensive orthopedic care. Sometimes hard to figure out, is it your back, is it your hip, is it your knee, where is the pain coming from, and kind of what's going on, and we have the people to figure it out, whatever it is, so getting you in and kind of, we share a lot of patients back and forth for various things, especially in the aging population. And, today we'll talk a little bit about, a few variations of this talk, good news for bad joints. We'll talk mostly about hip arthritis today. Big focus in my practice, along with knee arthritis, trauma care as well, but sort of addressing what it is, how it affects people, what we can do about it. I appreciate the comments from the last presentation about physical activity and its role in your overall health, and I think that that's something that I, like a broken record, I reiterate to people every day, is it's about continuing to be healthy, be active, do the things that you want to do, because it affects you in a lot of different ways, your heart, your lungs, your mind, in addition to just your joints. So what is arthritis? It's wearing of the articular cartilage. So if you look sort of on the bottom left, normal hip joint with cartilage capping the ends of the bones, that's what makes them slippery, smooth, what allows you to have range of motion, and protects those bone ends where all the nerve endings are. As it wears down, that sort of the tread on the tire analogy we talk about a lot, as it wears down, you end up with something more like this over here on the right. It's areas of bone that are exposed that are not protected by the cartilage. Your body makes a lot of these bone spurs that create a lot of the stiffness, the decreased range of motion, and the pain as well. And so we'll talk a little bit more about how it affects us and treatment options. The tried and true diagnosis a lot of times comes from the history and the exam. Just kind of old-fashioned medicine, but how much does it hurt? You know, how did it start? How long has it been going on? Did you have an injury or something that kind of kicked this all off, or did it come out of nowhere? So injuries and trauma is a big one. You know, active communities like this, golf, pickleball, things like this, generate a lot of our business. Family history is another big component of it. It's kind of the way you're put together, genetics, and some people develop arthritis very early in their life and some people much later, but there's not much we can do about that from the family history side, but it gives us a clue, you know, talking about, you know, how did your parents do, how did your siblings do, things like that. But essentially pain, swelling of the joints, stiffness, decreased range of motion, noisy, is it popping, is it clicking when you're moving around, things like that. X-rays are kind of the main focus of, like on an imaging front, it's sort of the step 2, that's the adjunct to it. It shows us the joint space, and we'll take a look at a few here. Shows us the alignment, shows us any bone lesions or things like that we're dealing with as well. And then on the hip side, MRI is a little bit more rare. Focal lesions, if you think of it more like a pothole in the road as opposed to the whole road being worn out. But definitely a useful tool for looking at things around the hip. And maybe more so useful in a few other areas. When you look at the x-rays, the focus is on the joint space. So if you look on the left, a normal joint space, we see a nice round ball and round socket, and then the space in between, that's the cartilage. Invisible on x-ray, it's holding the bones apart. That's how we know that there's a nice protective cartilage cap there. On the right, you can see an example of somebody with severe arthritis. So the joint space is worn down to nothing, and you know, you hear the term bone on bone, and that's kind of where some of these people are living. You have bone spurs around the side. You see the femur, the thigh bone, and the head kind of getting pushed out laterally, changing the offset of the hip as well, and that is an x-ray of somebody that's probably having a lot more pain, a lot more stiffness. The goals of treatment, whether it's with surgery or non-operative measures, which is where, you know, the majority of our patients land, is about kind of giving you your life back, getting back to the things that you want to do. So focusing on what is it that this is holding you back from and how we can get you to where you need to be. So pain relief, increasing your motion, improving your strength, keeping the muscles flexible, strong around the joints, and then again, just making sure that whatever it is that you want to do, whether that's golfing, pickleball, jogging, walking for exercise, or just being able to get around your house without, you know, falling or having pain and something bothering you. The early things, the place that we start for most everybody, activity modification, physical therapy. For just about everybody, physical therapy is beneficial. It's about keeping the muscles flexible, keeping them strong, keeping your range of motion. Activity modification, sometimes if you're doing high impact stuff, figuring out how to lessen that impact, lessen the duration of the high impact things. But we sort of try to meet everybody on their level of where they're trying to be long term and what they want to do. You see people after 18 holes of golf and walking a long ways and icing it down. That's a big component of it. Heat to warm up as well. Sometimes a cane, especially on the hip side, could be beneficial. Weight loss is kind of an underrated one, but it plays a big role. Joint reactive force, like on the knee side, maybe just walking 3 to 4 times your body weight and force can go across your knees. And on the hip, in a single leg stance, up to 5 or 6 times your body weight. So lose 10 pounds of weight, that could be 30 to 50 pounds off of your joints. And so it does make a big difference. Oral medications, anti-inflammatories, muscle relaxers, we have kind of a wide range of them that we can try and see what works for you individually. And then injections is kind of the big in-between step there. Some steroid injections. There's some promising things in the world of kind of PRP and hyaluronic acid that are sort of coming to the forefront here. Stem cell injections and things like that you'll hear a lot about and see a lot of ads for. I don't know if that's all the way here yet, but it's probably the way of the future. But a lot of options on the injection side, easy, fairly quick, low risk, and quick recovery. And so we do quite a bit of that. But the thing I focus more on is the surgery side. I tell everybody it's elective surgery. The exam, the x-rays, the whole part of it that I can show you what's going on and talk to you a little about your situation is is only half of the story. It's all about how the pain and how the dysfunction is affecting your life when we talk about elective surgery. So only the patient can really decide when it's time to move forward. So you think about how much is the pain affecting your daily life? Are you missing out on, you know, events with your family? Are you not doing the things that you used to do? Is it holding you back from the activities you want to participate in? Walking, exercise, sports, shopping is a big one that I hear. I can't make it around the whole whatever, you know, insert your favorite store without really being held back by this or taking a break. Visiting family, grandkids, things like that is another big one. Is the pain interfering with your sleep? That's another big one. If you can't get any rest and then you're tired all day, and that's, you know, another one that kind of tells you when it's time to do something about it. Is being inactive, unable to exercise, you know, is it causing weight gain? Is it causing deconditioning? Are you getting weak from it? And like I said, patients let me know when the time is right. You know, you think about all of these things and kind of put the pieces together, and my side of it is half of it, and the patient's decision is really the other half. So what are we talking about with hip replacement specifically? Look in the top left, you see a hip with arthritis, with the joint space has been worn down. There's bone spurs around the perimeter. It's effectively, we make a cut across the neck of the femur, get rid of the old ball that's worn out, and replacing it with a stem down inside the femur. It's got a porous coating on the outside that your bone grows into and attaches to over the next 4 to 8 weeks. And then that kind of becomes your piece permanently. The pink ceramic ball on the end, and then on the socket side, a metal shell with a little plastic lining inside there. From an x-ray standpoint, you can see down here at the bottom, so pre-op x-ray with no joint space there and bone spurs around the sides of the socket, and then post-op, the dark white being the metal, so stem inside the femur, a shell inside the acetabulum, plus or minus maybe a screw for a little extra fixation on that side. The most exciting thing on the hip side to me, the anterior approach, I think has really come to the forefront over the last decade to 2 decades, depending on who you talk to. And I think it's made an enormous difference in the recovery, the stability, and just sort of the ease of getting through the surgery and the aftercare. So muscle sparing approach as opposed to splitting through the muscles on the back of the hip. It's sort of moving everything out of the way. The only thing that really is opened up or kind of you know, cut per se is the capsule of the hip to access inside of it. It allows for a supine position, so laying on your back. Anesthesiologists love that for access to the airway, but it also allows much easier use of anesthetic techniques that encourage early recovery. So just spinal anesthesia, just a shot in your back, and then a very light sedation, so you're asleep, you're not feeling anything, seeing or hearing anything. But then when it comes time to wake up, it's a much faster process, a lot less groggy, a lot less, you know, time to get back to a normal mental state. It allows us to use image-based navigation, which is a great piece of the puzzle to make sure that everything is exactly the right size, is exactly where it belongs, and that we're giving you the best odds for getting back to the things you want to do. Improved stability, that's a huge one. So the risk of the ball popping out of the socket much lower with the anterior approach, probably in the 0.2% range compared to 2 to 3% for posterior approach, depending on whose study you read. As I said, the improved early recovery, these are the people that we see coming back to the office that feel, you know, dramatically better than they did before surgery, even just, you know, a short 2 to 3 weeks later in a lot of cases. A quick word on the bikini incision is something that I've been doing a fair amount of. You can see kind of the difference here. There's the blue line as opposed to the red as a traditional longitudinal, but it makes a really beautiful scar. You can do it sort of with a little bit of a mobile window. It fits into the skin crease, but the reason that I love it is it heals up super fast. It's just the way that the skin likes to fall back. It barely requires any suturing to kind of hold everything back together, and so they heal really reliably. They heal really fast, and the side benefit is it looks nice afterwards. It's something that can kind of fall into a skin crease, and you don't see it all the time. Common questions people ask about joint replacement. Most of the time it takes somewhere in the hour and a half range. We certainly prioritize time more so from an infection standpoint than, just the amount of time that the wound is open. The shorter the better, but it's pretty quick, and then it's, on to the rehab portion. So most people are up and walking the same day, getting up on a walker, moving through the hospital. I'd say probably, hospital stay 0 to 2 days. It depends a lot on sort of what your pre-surgery function is. Probably somewhere in the 2/3 range, go home the same day, with home PT, home nursing visits, things like that. But it's where you get your best recovery is at home. A week or two on a walker, some people as little as 2 or 3 days, and then getting onto a cane, and the goal being getting you back to walking independently and without issues. The sort of total healing time, a lot of people ask me, when will I know exactly where I'm going to be long term after this? It can take up to a year, really. But I would say 85% of the recovery happens within the first 6 to 10 weeks. And so once we get that kind of 6-week point, we know that your muscles have recovered, then that's kind of when I say it's no restrictions. Any position you want to be in, anywhere you want to sleep, across your legs, you want to do some jogging or impact stuff, I think all of that is okay, somewhere in that month and a half range. And then return to work and driving depends obviously on what kind of work you do, but a lot of people pretty quickly, somewhere around, if even on your right side, you can be back driving within 3 or 4 weeks in a lot of cases. And that kind of gives you back the opportunity to be independent again. I have a lot of patients that are back to golf, tennis, hiking, working out in the gym, anything that you're interested in doing. I discourage a little bit more some of the people who want to go snow skiing, marathon running, things like that, but there's definitely plenty of them out there. The implants can last a long time. 25 years is sort of what I tell people is sort of a general idea, but with the advances in the technology of the pieces, the better plastics that we have, especially over the last 20 years or so, I think that it's not unreasonable to think that even for people that are in their 50s and maybe even into their 40s, a lot of the stuff that we're doing today can realistically be a one and done surgery for them. Some of the things that we're looking at for the future, I think, just like every industry that exists out there, the technology is kind of is leading the cutting edge of it. So the navigation, I think, is a big thing, which is like making sure that the pieces are in the right place every time, that they're the right size, that we're minimalizing the invasiveness of the approaches. So smaller incisions, less soft tissue trauma, faster early recovery, but without compromising anything on the back end in terms of what we get. As we do more and more of these, it's figuring out how replaced joints are failing and what we can do about them. That's a big area of interest. A lot of people that have had, they had their knee or their hip replaced, a decade ago, and it's been starting to be painful. And so what's going wrong with it? How can we treat that? That's a big area of interest of mine. The rapid recovery protocols, I think, is the biggest thing. It used to be that you would get pre-admitted to the hospital, you would spend a couple of nights there getting a blood transfusion, getting ready for your hip replacement, and now it's like you live your life up to the day of surgery, you come in, you have it done, and you go home the same day, and feeling pretty good within a couple of weeks. So I think that's figuring out how to make it as least disruptive as possible. And then on that same note, the pain management, anesthetic protocols, figuring out how to make it the most pleasant experience that it can be, and I think that we're making a lot of progress in that front. I think that's all I got. Questions?
Are there partial hip replacements, like partial knee?
Yeah, good question. So the knee, I think of more like 3 compartments. So the medial and lateral side between the femur and the tibia, so the bones of the thigh and the leg, and then underneath the kneecap. And so they're all together in the same joint, but you can have arthritis and wear distinctly in one versus another. On the hip side, it's kind of like one compartment, and so there's not a way to do a partial hip replacement for arthritis. You hear about that a lot in the sense of if you know, so a fair amount of hip replacement is done for fracture, for falls and femoral neck fractures, and so if you have a normal intact socket and you just have a break across the neck of the femur without much arthritis, you can do a partial hip replacement, meaning just the ball side. But that's more of a fracture thing. But on the knee side, certainly, I mean, you know, maybe 70% of arthritis is primarily in the medial compartment, the inside of the knee. And so if you have isolated wear of the medial side of the knee and the other two compartments look pretty good, then, you know, a partial knee is a great option. It's actually a little bit more surgery, believe it or not, just because of exposure challenges, but it feels more like a normal knee that recovers a little faster, and so we do quite a bit of that. Yeah.
I got a question. Sure. So this is what I see a lot of, and this is probably a good, you know, explanation for a lot of folks out here, but I mean, you have the pain, you have the people that present with like the traditional pain, like in the groin from a hip, but then I get a lot of these other subset of patients that, you know, they're having like lateral hip pain or, you know, back pain or knee pain, and when you do an exam, you realize like their range of motion in one hip is terrible. Like, at what point, and they're not actually having the pain in the hip, so at what point, you know, are like altered gait mechanics or just terrible range of motion an indication for a hip replacement? And then, if you get those patients, I have one right now, and her rotation is terrible.
Yeah.
And then, so, and it's been like that for a long time, and I almost guarantee that's why she's having pain elsewhere.
Right.
But can she expect to get range of motion back if it's been like that for a long time from getting the hip? So, yeah.
Definitely. So a couple of things. I'll try to unpack all of it, but
Yeah.
a couple of really good points though. So the stiffness is a huge piece of hip arthritis, and it's especially like the one that I think about the most is flexion, adduction, internal rotation. So you see a lot of these people with their hip flexed to 90 degrees, and they try to internally rotate, and they get basically to straight, and then they have nowhere else to go. And that's usually bone spurs on the front of the femoral neck. So number one, everybody who comes to my office with knee pain or low back pain gets just a single AP pelvis x-ray for that reason, because in some cases you'll find people with just referred pain, they say mostly their thigh, mostly their knee, and it turns out they have horrible hip arthritis, but just the way that their sort of nerves are put together, it doesn't signal it as classic groin pain. So I'm always screening for that, because you don't want to be operating on somebody thinking they have a meniscus tear or for, you know, kind of mild knee arthritis and replacing their knee when really their hip is driving all of the symptoms that they have. The stiffness of the hip puts a lot of strain on your low back, and so in all cases with hip replacement, your range of motion is going to improve dramatically. So, you know, it's kind of a time of surgery assessment that any of the bone spurs that are impinging, any capsular stiffness that you have is going to get rid of that. But a lot of times, if your hip is so stiff and then you start to feel it in your back, it's because when you sit down, if your hip can only flex 60 degrees and you need 80 or 90 degrees to sit in a chair, the rest of that is accommodating for your lumbar spine. And so I would say not uncommonly, people that have hip arthritis, that have back pain, that have hip replacement surgery come back and say, yeah, you know, my back is not bothering me nearly as much as it was before, because you're basically taking a lot of that extra strain and load off of their back.
So they get that range of motion back.
Yeah,
Yeah.
definitely, right. It's just because of the constraint of the native hip joint, it's like, and with, you know, some of the modern stuff, large femoral heads and things, we can give everybody back, you know, near close to full hip range of motion.
Which is not necessarily the case with the shoulder or a knee.
Right,
Okay.
exactly, yeah. Those, in some other joints, stiffness is much more of a problem, but in the hip, reliably, we can free it up.
Cool.
So after a knee replacement, there's different information out there. Is it all right to kneel and do kneeling exercises?
Dr. Mahoney, can you repeat the question?
The question was basically about kneeling after having knee replacement. And there's a lot of things that go into that, but the general consensus is I think so. There's a great debate among the groups of people who do knee replacement about what to do with the kneecap, right? And so if you believe in the patella as a generator of pain in the kneecap and you resurface it and cut it thinner and put a plastic on the back of it, then some people would suggest that kneeling on it is putting you at high risk for an injury to it or things like that. But I don't know that that's the case. It's more of like a symptom-based thing. I mean, we try to move our incisions a little bit, medial to the midline to keep it right off of the area where you're going to be right directly kneeling on. I think that preserving the native patella is a big component of it, but it's kind of, as silly as it sounds, it's like the old-fashioned, like, if it hurts, don't do it. But is it, if you're comfortable with it and you can, I have a lot of patients that say, it's like when I go to mass, I want to be able to kneel down. And is this something that's safe for me to do? And I think by and large the answer is yes, it is.
If you've had knee replacement and then it's time to get new parts, is that surgery as complicated and hard as the first?
Good question. And the answer is it depends. In a lot of, if it's just from a pure plastic wear standpoint, so you think about like resurfacing, or it's like taking a segment of bone off of each the distal femur and the proximal tibia, metal parts to cap the bone ends, and a plastic spacer in between. If you started out with a great knee, it recovered well, it's been functioning well for a long time, and now it's unstable and you're getting recurrent swelling because that plastic has been worn down thin, then swapping that little piece out that's modular, the plastic that just snaps into the tibia, that's quick, that's pretty easy, that's a very straightforward recovery. If you have an infection, if you have one of the pieces come loose from the bone, we're talking about taking the metal pieces off of the ends of the bone and redoing them, then you're sort of, then it's kind of all bets are off. You're looking at, another, more extensive recovery than that. So that's kind of the challenge, is figuring out a lot of these, and I see a few of them almost every day. It seems like it's been functioning well for a long time. I had it done whether it was 3, 5, 10, 20 years ago, and it's been starting to bother me. It's like, well, what is the pain coming from? Because I can't just do surgery for pain like I can in a simple case where it's like you look at arthritis and you say the arthritis is causing your pain. So is it loose? Is it infected? Is it, is there a fracture? Is it a problem with the kneecap tracking? It's a little bit more individual, but so that's kind of a way of saying maybe, maybe not, but it depends on sort of what the indication is.
Is there a risk of getting, a high risk of getting arthritis if you have osteoporosis in the hip? And then how do you tell the difference?
Yeah, so not necessarily related in a traditional sense, in that I don't think there's any correlation, formally between like DEXA scan numbers and risk of arthritis, but could you be at more risk for sort of like insufficiency fractures or things like that? You feel like more at risk for having an injury that then predisposes you to arthritis, perhaps, And so those two things do go a lot of times hand in hand, but maybe more from a causative side, in the sense of like osteoporosis is a lot of times seen in people that are older, who have more predisposition to arthritis otherwise.
Okay. What about chronic bursitis? Does that generally lead to hip replacement?
Good question. That depends on a few things, like from a mechanical standpoint. Bursitis, which I didn't talk much about, but another very common thing that we see. So lateral hip pain, and it's like we blame the bursa for all the pain, but in some ways it's more of a symptom than sort of the cause. So it's a combination of tendonitis of the abductor tendon, so the gluteus medius, gluteus minimus muscles that combine to the simple thing they do is extend the leg laterally out to the side, abduction, but they're also very key in balancing your pelvis while you're walking and things like that. And so tendonitis in those muscles. There's a little bursa where their tendon glides over the bone of the side of the femur, and so that, as a result, can get swollen, can get inflamed. And then the third contributor to it is a lot of times a tight IT band. So the fascia of the whole side of your leg being tight and pressing up against it. So the bursa is swollen, it's inflamed, and then it's getting squeezed over it. There are a handful of options for that, but generally different than hip replacement surgery. So Similarly, like injections, physical therapy, stretching, a lot of those things work very well. And then when you get to the surgical side, it's like you can, if it's mostly a factor of IT band tension, you can release the IT band over it, make a little hole in it, a little window, so that bursa has some room to breathe, so to speak, which a lot of people get relief from. There's some endoscopic techniques where you can look with kind of like scoping your knee, but it's sort of outside the joint of the hip, that looking with a camera, trying to debride a bunch of that inflamed bursa and get rid of it. If there's a tear in that tendon, like a piece of it that's torn off the bone and retracted, lasso it with a suture, tie it back down with an anchor. But by and large, a separate entity, but very commonly seen together.
So you mentioned that the hip replacement lasts 25 years. Is that similar to the knee? And if
Similar.
you're active on the knee,
Yeah.
does it shorten that time?
I think that the native constraint of the hip joint portends a better long-term prognosis if you look back at some of the traditional data. I mean, the tough part is we can't get any of the data without, you can't get 25 or 30-year data without waiting 30 years.
Right.
And a lot of like, yeah. So that's the trouble. And I mean, if you look at some of the best long-term data, I mean, one particular study, the Karai, that has, a good 30 and even a 35-year published series, it's like 86% of the people that they followed have passed at 35 years, right?
Okay.
But among those, the survivors, it does very well. But I think that some of the newer knee designs are going to prove to last a lot longer. And a couple of things that makes a big difference in that is cement was always a gold standard in the knee because we didn't know what to do with the kneecap as much in designs that had porous surface on the backside. And so some of the newer the cementless designs that your bone grows in and attaches to, I think those are permanent, those are over lifetime. And then the plastic surfaces are so good that I think that, if you're in your 40s, I'm maybe hesitant about doing a knee. But once you get into your 50s, I think that if we can survive the first 10 years without fracture, infection, loosening, things like that, that I expect those to be a lifetime as well. So maybe not as good of a track record historically as the hip, but I think some of the newer, and then the other thing on the knee side, you can talk a little bit about, mechanics and alignment strategies, but I think that we've made a little bit of progress there in terms of the durability. But the biggest problem with knees is they don't feel as normal as your native knee. Hips, I think hips, most people, when they get through the early recovery, they get out a few months, then it's sort of like the forgotten hip kind of thing is what we talk about, is I want to get you to the point where you don't think about it every day or really ever again unless somebody asks you about it. And on the hip side, can get almost everybody there. And on the knee side, a lot of people say, yeah, it's very good, but it's still, it clicks, it makes a little noise. It's not 100%, but it feels great.
So Dr. Mahoney will be staying too afterwards for any questions, and then we can bring in Dr.
Yeah.
Claire.
Thank you.
Worth a try. When I think about PRP, I think for tendinopathy.
So I'm Michael Claire. I'm going to talk a little bit about why your foot and ankle might hurt. And I'll contrast Dr. Mahoney's talk in that I would say arguably that this area of the body is as complex an area within all of orthopedics in terms of it encompasses kind of a microcosm of all of orthopedics, but in a much smaller surface area, and it's a little more challenging, a little more difficult to deal with in certain instances. So why would someone end up seeing a person like me? A lot of times with fractures. So think of, there's a slip and fall in the upper left, that's a fracture dislocation of the ankle.
Could you speak up a little, please?
Okay.
Thank you.
So on the upper left is a fracture dislocation of the ankle. So somebody slipped and fell and the rotational type injury, and that's what was done to stabilize this. This in the center is a calcaneus or heel bone fracture, so you fell off a ladder, so it's strongly, you guys live in this nice gated community, pay somebody to do it. You need to be up on a ladder or on the roof, not a good idea. And this, this example here on the right was a guy that crashed his motorcycle, and this is all the hardware that he had to put all those things back. So be careful on your motorcycles and your e-bikes and scooters and all that too. Or if you do, wear a helmet. Sprains and
Oh.
ruptures, so tennis and pickleball, you think of that kind of thing on the pickleball court. And then the Aaron Rodgers thing, but, so pickleball has been very good for our business. And
Yeah.
warm up, stretch, be conditioned before you play and so forth, and kind of use common sense with it, maybe stick to the doubles rather than the singles. Tendinitis, so this example is an example of what Achilles tendinitis looks like in terms of where it hooks into the bone. You notice the big spur where the tendon hooks into bone, and that's the body's reaction of chronic inflammation. It wants to try to immobilize itself or react to it, so it lays down this big spur, and this is all degenerative. And so a lot of times it's, the tendon will be thickened and a source of chronic pain and so forth. And here's an example of kind of what is done in terms of decompressing the area and cleaning up the tendon and reattaching it over time. Arthritis is another big player, and you can't just lump every type of arthritis in the ankle or foot into one. There's lots of different variations and subtleties to it. So here's an example. On the left is a guy that was a younger guy with ankle arthritis. Most of arthritis in the ankle at least, is more post-traumatic, so had an injury, had a fracture years ago, rather than wear and tear that you see more in the knee and the hip. And so in that particular instance on the left, he was still in his working years, did a very physical job of lifting, climbing ladders and so forth. And so for him, it made more sense to do a fusion. And so we fused his ankle, that's what this is, basically removing the cartilage, positioning the bone, stabilizing it, and getting the joint to grow together like healing of a fracture. Where in this instance, you're relying on the motion of the surrounding joints to give you some up and down motion, certainly not normal motion, but from a pain relief perspective, it works well. In the middle is more of a kind of a deformity type ankle arthritis in an older person. And that was where this is what an ankle replacement looks like. Kind of similar principle to knee and hip arthritis in terms of how the diseased portion of the bone is removed. There's metallic portions on either side of the bone with plastic in the middle. These are the happiest patients I have, and it's not close. But you know, clearly it's not for everyone, and I get asked the question a good amount: how many of these do you do, or is this a common thing? A busy knee and hip guy will do more knee and hip replacements in a month than a busy foot and ankle surgeon will do of these in a year. So the busiest people in the country average about 30 a year in terms of ankle replacements, and that's not very many because not everyone is a candidate for it. And then lastly, here's an example of arthritis from a flat foot deformity involving a tendon that helps to hold up the arch. That once that tendon stretched out, the foot shifted, it became arthritic, and this is a fusion of various joints to realign and stabilize. So there's lots of different variations within kind of my area of the body. Yes, we've highlighted surgery and stuff, but the majority, as Dr. Mahoney said, the majority of patients don't need it. And so a lot of times it's various things, the braces, orthotics, anti-inflammatories, certain cortisone injections for certain things, physical therapy, stretching, and then on occasion if those things don't work, there are surgical options depending on the individual problem. As we mentioned, we have 3 different offices. The closest one to this area is clearly Lakewood Ranch. Nice little facility. We have physical therapy on site, multidisciplinary type approach. And with that, I can open for questions or comments.
If you have a non-traumatic pain in your foot, how do you determine whether you see an orthopedic foot
That's a loaded question. I have a little bit of built-in bias.
Is the answer never?
Yeah.
Yeah, that's a good question. So it's, yeah. Yeah, I'm not entirely sure how to answer that.
Well, for instance, in Florida, lots of people wear flip-flops all the
Sure.
time. Flip-flops, I have found, don't have the arch support that
Sure.
one needs, and I developed pain in my cuboid bone
Mhm.
over time because of wearing improper footwear.
Mhm.
So I went to a podiatrist.
Mhm.
Should I have come to an orthopedic foot specialist?
I think certainly there are way more podiatrists than orthopedic foot and ankle surgeons.
Right.
And so I think the question is, I think the key thing is if what you're being told makes sense, and if it's, if there's not a suggestion to, go get custom this, that, and the other that's gonna, be out of pocket. And if it passes the smell test and makes sense,
Okay.
then you go, then that seems reasonable.
Okay,
And I think if you have a realistic sense of, okay, how long will this take to get better? What's the realistic thing? What is it? Have you determined, what the diagnosis is, what a treatment plan is? What's the next step if this doesn't work? Things like that. As you would with most any other area of the body.
Any new treatments for plantar fasciitis?
Plantar fasciitis is kind of that's a challenging thing, and there are lots of things listed and lots of treatment modalities and so forth. And in general, probably stretching is the most common thing that tends to work. It's a frustrating deal. And I think the big thing to remember with that is if you think about the natural history, so what does natural history mean? Meaning if you ignore it and you do nothing, the overwhelming majority get better. In other words, it goes away. But stretching can kind of help the process along. And so yeah, there are lots of things listed, which means not any one thing does the trick.
So my ankles are very weak.
Mhm.
Stretch them, rolled them, all through sports and stuff. And I've done PT and they're still weak to the point where I'll roll my ankle just walking with bare feet. Can ligaments actually be strengthened if they're, I feel like it's a rubber band that's been stretched so much that it just won't, it lost its elasticity. Can
Yeah,
they
so-
be, or is surgery the only option?
Well, so I think in terms of ligaments, you can't necessarily strengthen, but
Okay.
when it comes to, I think there's a spectrum of natural flexibility. So some people are loose jointed, naturally flexible. Other people are tight jointed and not, and more stiffer, if you will.
Okay.
And so there's kind of a spectrum to it.
Okay, so it's not the ligaments that were, it's, okay, cause I just saw two doctors, a podiatrist and a foot surgeon, and they're both saying how lax I am.
But that may be your normal. So
It
if-
could be my normal,
if
'cause
you're
I'm flexible
naturally-
everywhere.
Yeah, if you're naturally flexible everywhere, then, and there's not necessarily asymmetry one side versus the other, then it comes down to probably the most important thing is strengthening, and strengthening your stabilizing muscles as much as possible.
Okay.
But
Would an MRI tell me if it's able to strengthen, or if it's just
a
with?
lot of times it's just, putting hands on it
Yeah, I
and
mean, they were
assessing
saying it was
strength.
really loose, I don't
Sure.
know, I'm just,
Yeah, I mean, the MRIs can delve into what your cartilage looks like and so forth, but it's gonna pick up that you had a sprain at some
Oh,
point.
yeah.
And it can't determine how old it might be, or
Oh,
how
they
many
won't.
times. No.
okay.
Does
Or if I was
LRD
born that way.
Does Ehlers-Danlos affect the feet?
Sure.
Would
Yeah,
feet too?
For sure.
Are you hyperflexible elsewhere?
All, everywhere.
And there are components of that,
Okay,
and it's, a subset, and so it's one that, it's not that difficult to stabilize ligaments and so
How much
forth.
therapy are we talking about? I mean, like PT and strengthening, like I've been through it my whole, I was a volleyball player, I did it. And yet here I am today, still just rolling.
Yeah, sometimes it can also be,
stepping
alignment, so if you have kind of a subtle high arch, and if you wear your shoes out on the outer border, or things
Okay.
of that sort, that kind of creates mechanically a tendency to want to roll. So that's a not an uncommon scenario.
What about invasive versus non-invasive bunion surgery? I mean, when do you know? I mean, I have issues with bunions for many, many years and still able to do everything, but it definitely is impacting other parts of my leg, you know, and when do you know? Like, if you hear about this, you know, non-invasive bunion surgery, I don't know.
Yeah, it's a little bit of an oxymoron. So there are small incision type bunion surgeries that can be done that have become fairly popular. And to say that it's not invasive isn't necessarily true. It just means it's small incision, and there are certain instruments that are developed to be able to cut the bone, and rather than opening everything up, it's a small incision. So theoretically, things should heal a little quicker, and it should be a little easier recovery. But it's also one of those things that it's still a surgery, and no matter, you know, any of these things, surgery-wise, are not going to be, hey, in and out in 4 weeks, no big deal, feeling good as new. Realistically, these types of surgeries tend to be more like 6 months, and that's just, there's no way around it. It has to do with the weight-bearing area, and that when the bone is smaller, there are smaller implants that are not strong enough to hold body weight right away, so you have to be off of it. It makes you decondition, you lose muscle mass, and you have to build it back up, swelling and all those things. So it's, you kind of in your mind, if you go that route, anticipate it's going to be a good 6 months to get it right. But in terms of making the decision, ultimately it comes back to much like pulling the trigger on your knee or your hip. Does it bother you enough? Does it interfere with the things you want to do enough to go through something that's going to occupy your life for up to 6 months? And that's the time, you know, that's the decision making. It's an individual one. So I don't think anyone can make it other than you.
Thank you.
Crystal clear.
Well, thank you very much. So thank you all for coming tonight. We hope that you'll look in the River Strand website for the other Fitness, Health, and Wellness Committee meeting, or at least twice a monthly lectures till the summer. Hope you all consider the scavenger hunt, and then we'll be in full swing again next high season for multiple times each month. Thanks again.